le flux. Ota, tu peux juste me confirmer ensuite que ça se lance bien, s'il te plaît. Et normalement, on est bon dans 1 minute.
Attends, il y a Ben. Alors, normalement, t'as lancé quelque chose là sur l'Insta?
Ouais, c'est tout. C'est tout bon là?
Oui. Ouais, ça peut ça. C'est
Alors,
Betty, par exemple.
C'est bon, Alex.
Ok,
bon,
super.
Ouais. Super.
Alors, tu peux gérer toi tout seul là, parce qu'il y a seulement une personne qui peut se connecter. Ok?
Ok, ça joue. Parfait. Très bien. Ok.
Bon, normalement, il n'y a rien à faire.
Ouais,
Voilà.
c'est bon. Et ben, donc, on est live. So, we are live today with the Master of Microinvasive and Aesthetic Dentistry of Geneva and Pascal Magne, who kindly accepted this invitation. So, I'm really glad that he joined us for this question and answer session tonight with our group and also on Instagram, so we can share with as many people as possible. So thank you so much, Pascal. I'm not so sure there is a big need to introduce you because you are the father of, let's say, adhesive and biomimetic dentistry. Well, for some people, at least a lot of people, and also proud father of the biomilation group. So it's a really big honor to have you, Pascal. So the topic today will be to discuss about two different subjects with let's say clinical also aspects, showing you some cases. And so I'm going to start to share my screen. If you want to say a few words before we start, Pascal, you're more than welcome.
Okay, thank you, Alexandre. Thank you very much for inviting me. My great pleasure to be here and take advantage of those amazing new opportunities that have opened up with technology. It's wonderful how a crisis can be used for the good, right? Something bad is used for the good, and it reminds me the story. I don't know if you, for those of you who read the Bible, there's one of my favorite stories, the story of Joseph. And Joseph, if you look it up, he was sold by his brothers as a slave to the Egyptians. And you know what happened? He ended up to become the savior of the entire Israel people. And so you see how something that started really bad ended up as kind of a salvation story. And I think this crisis is amazing because you see, if we didn't have that kind of situation, I don't think we would have the idea to be all together like that and share life. So it's like the good news in the bad news, right? So I'm really excited. Thank you.
Okay, great. I totally agree with you. This particular time is also really a good opportunity for us to get connected as much as possible. So we're taking advantage of that. So I'm going to share my screen. And we're going to start with just the first topic. I don't know if everything is working well. Normally it should. Okay. Can you see my screen, Pascal?
Yes, now it just appeared.
Okay, perfect. Yeah, there may be a little bit of latency between the feed and what I'm saying. So we chose two topics, basically. The first one will be veneer restoration and color tooth, okay? And we wanted to talk about the fact that when we are facing really discolored tooth, and when, for example, in this situation, we have quite a huge amount of structure, and then the ideal restorative treatment of choice would be probably a veneer, or let's say a full veneer. What could be the ideal approach and protocol in this type of situation? Dealing with the loss of structure in terms of materials, and also dealing with the coloration of the substrate. So what is your take on this kind of situation?
Absolutely. Yeah, so that's a fantastic case. Of course, you can very quickly understand the depth of the problem, which means that we have a discolored tooth first. Looks like it's a non-vital tooth, right?
Yes, I believe so.
Yes. So discolored, non-vital. Actually, it doesn't really matter whether it's vital or non-vital to me, but of course, it will make a difference in terms of the treatment of the discoloration. So to me, that's a perfect tool for internal bleaching, followed by an adhesive restoration. We have a lot of ferrule effect remaining, as you can see, from buccal and lingual aspects. So first question that I will answer rapidly, I would never use a post in a tooth like that because of that ferrule remaining. But even nowadays, with our most in vitro data, it needs to be confirmed by more in vivo data. But even if there was no ferrule, the use of a post could be questioned here. Okay, so now you can do internal bleaching. I would do that in order to improve the outcome of the adhesive restoration that we would place on top, right? So now for the restorative treatment, you have a number of options there. And it's all going to depend on, cost analysis, antagonistic teeth, wear, maintenance, aging that you expect from a restoration like that. And because we all know that the most durable restoration in a tooth like that would be made in ceramics. That will give you the most stable result. And I tell you, after 20 plus years now, when I see my cases back, ceramics is unbeatable in terms of outcome in the long term without any maintenance. I mean, that's unbelievable. Composite will wear off, composite will chip more easily and will require more maintenance. But composite is not contraindicated in a case like that. So, I always look at it like that. It depends a little bit who is restoring that case. If it's someone who has access to a master ceramist and the patient has limited financial options, then of course ceramics is the best way. And I would do a small composite build-up on that tooth. I was used the internal access preparation on about 3 to 4 millimeters to bond a small build-up. The build-up could even restore the lingual surface and then cover it with a bonded ceramic restoration type 3. Like if you look at my book, I would put that under the classification, a type 3 bonded porcelain restoration. And we've done that in cases like that, vital or not vital, and they work fantastic. The thing that I might do different today that I did in the book was the composite build-up to add a little bit compliance to the restoration. Because what we noticed is that with a full ceramic fragment, let's say a monoblock ceramic restoration in a case like that, if the patient has a secondary trauma, there's a higher chances to break the root than if you have an integrated compliant element in form of a composite buildup. So that would be my choice. Now, if we have to find for socio-economic solutions, now we have step 2, which is so step 1 would be the non-social economic. So we have access to an amazing master ceramist. Because to me, that's one of the most important things. I will never do ceramics if I don't have access to a master ceramist, right? So that's my no. If I have mediocre technician, I'm not going to do ceramics because I did that mistake many times in the past. And every time I wanted a veneer made by mediocre ceramist, I wanted to cry. And so if I'm going for ceramics, I'm going for the top. That means master technicians, that means a champion ceramist, that means someone who is not going to do it for a cheap fee.
Yeah, of course.
And so, a restoration like that is the most expensive ceramic restoration you can buy because it's a single central. Of course, we could debate whether the other central needs something too. And we could debate whether to include the other central with a very conservative veneer in order, because you can see some signs of suffering, existing restoration. I don't know if there is even an existing class 4 restoration on that too.
Yeah, there is.
But so that could be a package, the 2 centrals. If you do ceramics, definitely it would increase enormously the long-term follow-up of that case, be to enhance the long term because you have 2 centrals restore identically. Okay, now We have the social economic approaches, right? Now with composites. Now we have two options with composite. You have direct or you have semi-direct with CAD-CAM, right? And so now we go down the ladder of complexity and cost. So number two would be the semi-direct CAD-CAM, customized, composite resin block, cut back, customized, same design like a monoblock restoration. And then number three would be the direct composite, because we've seen direct composites work in an amazing way in cases like that. So again, first decision would be, based on cost and patient possibilities and access to a ceramist, ceramics, or option two, direct or semi-direct composites based on your abilities. Some people, personally, I like both. I think they have both an amazing outcome. With a large volume like that, the advantage of a CAD-CAM block is to give a strongest base to your restoration. So this is a little bit my analysis for a case like that, but I'm totally open to your questions and comments.
Okay. So maybe there is one thing that we can discuss about, and if any one of you guys want to join the conversation, but regarding the masking effect of, let's say, veneer ceramic, what would be, according to you, the best way to deal with, let's say, if this tooth wasn't that, let's say, short, without so much lost structure, how would you deal with the, let's say, masking effect? Because probably the internal whitening process wouldn't be that stable over time, let's say, on long term. So if you have a relapse, how can you make sure that even after the relapse, you will have something that can be as aesthetic as possible? Because, for example,
that's the big advantage of the ceramics, obviously, because the ceramics will allow you to include the concept that we describe in our book. Is called selective intrinsic masking. So with the ceramic, and even if I bleach, by the way, and I think I explained that in the book too, even if you do internal or external bleaching, when you do a veneer in teeth like that, on top of the fact that you need a delay before bonding, etc., before, I think that all of you know that. In addition to that, I will ask the dental technician, and my brother knows that when he does those veneers, to include a minimum amount of intrinsic ability for the veneer to mask. And this is why I don't like the so-called contact lens veneers. We don't do that. Honestly, I'm not a fan of contact lens veneers. That's not my vision. I've seen beautiful cases like that, but to me, a contact lens veneer needs to be translucent. It's mainly made of enamel ceramics. And then it becomes more susceptible to the changes of the substrate. With Michel is using a technique where he's always using a base of dentin ceramics, even in thin layers, but there's always a base of dentin. And if there is intense discoloration, there's an article, a beautiful article he did together with Dr. Bazos in the International Journal of Aesthetic Dentistry that you can see about layering ceramics on severe cases of tetracycline, where he shows his technique of selective intrinsic masking. It's called also the parallel masking technique. And in that way, you can prevent even the changes in color in the tooth. So I would like to remind you, there is two types of veneers. What I call autonomous veneers. They secure the color by themselves, almost 70%. And then you have contact lens veneers that don't secure the color. They depend on the substrate, which is beautiful for some cases, which is a problem for another case. So you have to be careful when you do contact lens veneers. In addition, contact lens veneers are very delicate. They need to be delivered often with flowables, which is not my favorite luting composite. And then they can break easily. They are very difficult to fabricate, to manipulate. So that's not what we are talking about here. So this is a very important debate, because a lot of young dentists here are going into this contact lens approach without knowing these limitations.
Yeah, of course. But would it also, for example, in this second case where you have a really huge dyschromia of the number 21, and if you had to do veneer, because probably you can also see that there is a class 4 composite on the distal angle of this tooth, and we know that maybe the internal bleaching won't be enough to, let's say, to cover this discrepancy. Do you think that you will have to prep a little bit more in terms of thickness of ceramic to have this masking effect that you were talking about? The fact that you need this veneer to have this internal property to mask.
Absolutely. So if this is the substrate, so I'm not going to talk about bleaching, etc. So let's assume this is a case where that's it. You have to deal with that substrate, right? That's your question.
Exactly, yes.
Correct? Yeah. So in this case, the dental technician, in order, these are the worst case you can have for a dental technician, most difficult case you can have for a technician, because you have a beautiful bright tooth that's almost intact next door, and then you have this extremely discolored tooth. We could discuss about the laterals. That looks very weird, and even the canine on the left side, but that's another discussion. So this tooth would need masking. Masking means, the technology has evolved. Michel himself, my brother, has evolved in his way of masking, and in the recent years, he needs less and less space. He's more and more efficient. You never stop learning. But I know for sure that with his technique, he can apply a thin layer of masking porcelain. That's why I would refer you to this article he published in the International Journal of Aesthetic Dentistry by Quintessence there, where he explains exactly his needs. But in a normal veneer, Michel would ask you today about 0.6 millimeter of clearance. For a veneer like this one, he would need 0.7, 0.8 in order to add this extra masking layer, which is a wash of opaque porcelain that he would place on the refractory die before starting the regular dentin layering and then adding the enamel skin. So if you go to the book, you see his layering technique, you will completely understand what I mean when I say masking and when I say intrinsic masking and autonomous veneer. An autonomous veneer is layered with a base of dentin porcelain. And porcelain is different than composite. You cannot compare. What ceramists call dentin is more translucent than our composite dentin. And what ceramists call opaque dentin is more opaque than our composite dentins. So instead of having dentin and enamel, what they have opaque dentin, which is more opaque than our dentin. They have dentin, which is less opaque than our dentin. And then they have enamel skins that are basically incisals.
Yeah. But can you rely, even though you're going to choose a really opaque, let's say, dentin for your ceramic to have this masking effect, can you also rely on the opacity and color of the cement that you're going to use?
No. This is a myth.
This is a myth, right?
So yeah, totally. You see, you're relying on the luting composite. That's going to be less than, luting composite. I measured it in many of my researches, and when Michel makes the veneers with a very given layer of dye spacer, the luting thickness is about 120 microns. Take composites, take Herculite dentin or whatever classic composite, Herculite dentin, and thin it down to 20 micron. You cannot even see the color in it.
Yeah.
So, 120 micron is not enough unless you use an extremely opaque composite. And that is going to kill your restoration, because now you will see at the margins a very opaque layer. And again, this is an example where the entire tooth is discolored, but there are many examples where only an area of the tooth is discolored. And that would be foolish to mask the entire beautiful intact substrate just because of one area that's discolored. And that's why I'm not a supporter of using a composite to compensate for discoloration, which is very unpredictable also, by the way.
So does it mean that you're always choosing the same, let's say, shade of luting composite for the the looking
Right,
of the veneer.
right. I just match whatever my brother is using as a base. So that's why it's fantastic when you know your technician. When if you want to do beautiful veneers, my friend, I have only one advice to give you.
To have a good ceramist.
Find a brother ceramist. Find a brother. Everybody tells me, "Oh, Pascal, you have Michel. It's easy for you." No, it's not easy for me because, first of all, right now I cannot work with my brother. I have not worked with my brother or with any decent technicians now for the last 6 years. That's another discussion why it has to do with conflict of interest and stuff like that at the university. But just to tell you, for the last 6 years, what do you think I've done? I told you, because I cannot work with a decent technician. Basically, I stopped doing ceramics. I am not going to do ceramics if I cannot work with a decent technician. And so I've been focusing on composites for that reason.
Okay.
So the thing is, choose an excellent ceramist. Choose an excellent ceramist. Make him your brother. Find a brother out there. Make a brother. How do you do that? First, you don't have to talk ceramics with them. You have to go and invite them for a good dinner at a nice French restaurant.
Always French food.
Have a nice dinner, make friends, enjoy life a little bit together. It's like and to be honest with you, do you think it's easy to work with a family member? No. Working with my brother hasn't been easy every day, and we've had our clashes, etc. And so it might even be easier to work for you with someone who is not a family member.
Yeah, of course.
But you need to develop that bond.
Yeah, I totally agree.
It's another bond. It's not dentin bond. It's it's a double ceramic bond, a bond, a relational bond, and a physical bond.
Okay, I understand. There is a question from Jade. Jade, if you want to speak with Pascal, you're more than welcome.
Hello, Pascal. How are you?
Hi, Jade. How are you?
Very good, thank you. So I just had a question regarding when you were saying that your technician, your brother, is adding a dentin layer in the veneer to be able to mask the dark substrate. Do you lose any translucency and have a result that is less natural?
That's the whole challenge of masking, basically, because you need to create depth, but you don't have it. So it's an illusion, and that's where this illusion is extremely difficult to create, and that's why it's not given to every single technician to be able to gauge the exact amount of masking. And if my brother would be here, he would tell you this: when you have a case like that, you should never mask 100%. So the masking has to be basically toned according to the translucency, because exactly as you said, if you mask too much, it will look opaque. If it looks opaque, it will look different than the tooth next door. So this is where the magics happen. And dental technicians, like master ceramists, not everybody, and that's why you cannot do this nice with Emax, with a monolithic restoration, because this is like, it's an artisanal work. And so Michel, he knows exactly how much thickness and what he does for that, Jade. And you should go visit. I'm sure maybe you've visited the lab, but people who work like Michel, there are many of them in Switzerland. You have Dominique Vinci in Geneva. You have Patrick Schneider in Montreux. There is also Jem Piskin, amazing technician in Lausanne. Jem Piskin. I mean, go visit those guys. Go see what they do. And what you will notice is, like Michel, for instance, he's creating a stump. Michel, what is very important in a case like this is to provide a cross-polarized picture like this one, but not before, but during and after preparation. So whenever you deal with discoloration, you need a precise picture of the substrate, right? The substrate has to be visible very well after preparation. And it has to be compared to the reference tooth. For that reason, when you prep, there is always 2 stages in preparation. There is a wet stage and there is a dry stage. You understand that? The wet stage is you work always with water. So you start your preparation, everything stays wet. That means the color is not altered at all. The reference tooth next door and your tooth. You prep wet, wet, wet. You go almost to the final prep only with water. Then you take pictures. Pictures with the polarized filter and the gray background, the gray reference card. With that picture, you send to the lab with the gray background. The lab can use the eLab system or his own system. It doesn't matter, but I don't know if you are all familiar with the eLab system. It's a very important system.
We've talked about it at the university already.
Okay, good. So if with that picture of the exact color of the substrate, you can gauge, and he can fabricate stumps. He can fabricate ceramic stumps. And my brother will fabricate ceramic stumps, and he will apply to those stumps. He will make a bunch of them. He will apply a given layer of opaque dentin and fire it and look at it and compare it using, and now with the eLab system, it's fantastic. You can do that. And then he will compare it again and again and again until he has the correct amount of thickness of opaque. And he will again, that is the art of it. He will opacify enough, but not 100%. And I mean, you have to talk to those guys, and they would better explain than myself how they do that. But that's called selective intrinsic masking. And I want to really, really encourage you to read the article I mentioned already 3 times in the international blog. And I can send it to you if you remind me, Alexander. I have
I will let you know. So thank you again for your answer.
Thank you so much.
Before we proceed with the next question, I just have one that relates to what you just said. So if I understand correctly, and that was also the question from Nicola. So basically, you're only using feldspathic porcelain for veneer cases, if I understand correctly, even if you had to mask a coloration?
Yes.
You will never go for lithium disilicate, never?
No. And especially when you work with a master ceramist, they wouldn't either. I mean, I know a few ceramists who would do it, but to be honest, to answer Jade again, these are cases where you need a miracle to make that tooth look absolutely identical to the other. It will never be. I mean, it could be on one given picture taken with a polarized filter, but then you go outside and you have metamerism and it looks different. And so, especially when you have discolored substrates, the metamerism effect increases even more. So these cases can look good under one light, but not under another. But all my personal experience with Emax has been always disappointing. So
okay.
Compared to a fully layered feldspathic. But again, to answer the question, can it be absolutely perfect? No, it's impossible because you have a different substrate than the natural tooth. It's impossible to be perfect, but you can be as close as possible with a layered, selective intrinsic masking, a masking that's been gauged, applied, measured selectively for that tooth, not a given bulk of a material of a given opacity, a totally uniform opacity.
Okay, so I just put the picture of the gray card, with the stump shade, just to reflect on what you were saying, so that way people can see what it is.
Exactly, and when you do pictures like that, you see the picture you are showing is rather overexposed.
Yeah.
You should rather be slightly underexposed rather than overexposed. Yes.
Yeah. Yes. Okay. So there is a question from Marta. Marta, if you want to take the microphone and talk about, it's a really nice question actually. So.
Okay, thank you, Pascal. It's a really fast question. It's about when you said you prefer to go for a composite if you don't have a good technician with you. So when you're using composite in this kind of cases, do you use opaquer?
Do you use a
opaquer?
Oh, you have to. Okay, yes, you have to basically build it a little bit like the technician does, right? But we don't have absolutely always the same masses. But yes, you need to start with a base of dentin, and that will also take space, and that will also cost you opacity and all the same problems we are talking about. Now, if I do a case like that with a CAD-CAM block, because sometimes I have fractured, and actually in one of our recent articles, I have a similar case like that, but the tooth was fractured, 2/3 of the incisal edge, and only the cervical aspect was discolored. Because that was the only aspect remaining. Mm-hmm. And I use a low translucency block, and using Lava Ultimate. Lava Ultimate is an extremely fluorescent. Yeah, it was a case like this one, but the lower incisor.
Okay.
And the Lava Ultimate was good enough in terms of its opacity and fluorescence to give a light boost and mask the coloration. So this is going to be different according to different materials. Of course, composites with a good fluorescence, like the composites of Lorenzo Vanini, when you layer the cervical part here, are very important. To use a composite that is a dentin opacity and fluorescent, because this is the area of the tooth that also has an excess of fluorescence.
Okay, thank you so much, Pascal. So maybe it's time for us to go for the next topic, or if anyone else has questions on the first topic, you can go on. Okay, I think it's all good. So next topic will be talking about IDS, really interesting topic. Especially, yeah, I'm pretty sure that you're aware of that topic, that you've already heard about it.
I'm ready for all the questions.
Okay, great. I think that this is quite a common question, because we can hear a lot of things about this when we are dealing with endodontically treated teeth, and we can hear many different, let's say, approaches, protocols, and guidelines about when can we really bond on a tooth that has been endodontically treated, and what is the right timing. And so it relates to IDS. Can you do the IDS protocol if you're gonna have to do an indirect restoration? I just put this picture to highlight the fact that we are talking about endodontically treated teeth. But do you have to wait a certain amount of time in order to do the IDS if you want to go indirect, or you can do it the same day as the endodontic treatment?
So, well, there's a lot to say about this topic, but one thing that was recently published in Geneva, by the way, by the team of Dr. Kretschy, was pre-endodontic dentin sealing, right?
Yeah. Yeah.
I don't know if you are all aware of this publication, which is a fantastic idea. Actually, is an immediate dentin sealing before endo to prevent all the products from the endodontic disinfection to affect the coronal dentin. So I think the first thing you should consider before doing endo is to seal, clean up completely the coronal dentin, remove completely the diseased tissue, and then seal that diseased tissue before the endo starts, so that you will prevent the contamination of the dentin, alteration of the dentin by the endodontic products, right? And that's very important. Now, that allows you, once endo is done, to proceed. Now, endodontic products will alter the dentin and influence the amount of bonding to the dentin, and this is why we don't bond easily into the canals, right?
Mm-hmm.
The studies are clear about that, and that's why I don't think bonding into the canals should be a goal, because we all know it's difficult. So first of all, I don't think we need to bond into the canal, because we can bond to the coronal dentin, and the coronal dentin should be our focus for bonding. The problem is when we try bonding to the canal and the coronal dentin with the same stuff, we start running into problems, because these adhesives that are sold with the post systems are not good adhesives. So my goal here would be, number one, seal the dentin before you do the endo, so you prevent the alteration of the dentin. I think that ID from Geneva is amazing. It's super good. Then do your endo, fill the endo, and then I would place a glass ionomer barrier whenever you finish the endo, just as a separation between whatever you are going to do next and the endo part, right? So a little GI barrier. And then you go back to your coronal bonding. You can redo the coronal bonding, remove your existing IDS that you placed there, or complete it if new dentin was exposed during endo, and then go ahead with your build-up or restoration as you wish.
Okay, understood. I just have one question about the build-up, because that's what you mentioned in the first case, saying that you will probably go for, let's say, a small build-up of composite, just going 2 to 3 millimeter inside of the, let's say, chamber. So would you do that in all of your, interior cases? Are you trying to stay away from fiber posts?
Yeah. All right. I think I'm sorry, I'm going to shock you a little bit maybe, but I don't want to touch any post anymore in my life except to remove them. That's it. I'm not going to use any post anymore in any situation. From what I've seen in my lab and the recent research, by the way, on May 8th we will have an amazing biomimetic research talks on Instagram with I invited all my scholars to come and present the work we've been doing in the last 15 years. And one of them is Dr. Marco Carvalho, and we completed a series of 5 studies now in vitro about the use of posts, and it's shocking. Posts, in those studies, you look at the result, you're like, what are posts made for except giving us trouble? So I would never use any post in any of the teeth on the screen there, and any teeth at all.
Okay. That's
sorry.
When is it going to happen? This live on May 8th, you said?
May 8th, yes. We will still announce the time. Likely will be evening for you and morning here in LA. But we just made a preliminary announcement. It's called Biomimetic Research Talks.
Okay. That could be interesting. Two questions about IDS, still on the same topic, and then we will have 2 other cases to discuss. Do you still always use Optibond FL for your preparation, crowns or veneers? Or did you change your approach regarding the type of adhesive system? We're going to talk about that in the next 2 cases, but are you changing the adhesive system depending on the situation for the IDS? Or?
No. I think it's I'm not like for multiplying the amount of products. We have already so many products available to us, and when there is one product that is universal and indicated for all, why would I add one more product? I mean, make it more complicated. So if Optibond FL, which has benefited from so much research, so much confirmation, so much stability, so much literature, why would we change the winning horse? I really don't understand. Self-etching agents work great. SC Bond, SC Protect, great products. I'm not against. But simplification to save a few seconds here and there, why? Making that and then compromise for a few seconds. So Optibond FL, it's a fantastic adhesive. So we use it for everything. And I don't see, unless you give me a reason why have multiple adhesives. Honestly, I don't see why.
Okay. I understand. When we talked about pre-endodontic IDS, do you think it's relevant to only put the adhesive, do only the IDS strictly, or can you also do like a build-up, a composite on top of that? Or
right, a build-up is part of IDS, I would say. Margin elevation is part of IDS. IDS is contingent to all those techniques. So IDS can be a simple resin coating. It can be a resin coating covered with flowable. It can be a resin coating covered with composite. It can be all those things. That doesn't matter. But when you do build-ups, you always do IDS. When you do a direct composite, you do IDS.
Yeah, of course. Yeah.
So that's the point. Why would you do IDS when you do all your direct restoration? So why not do it when you do indirect restorations? That's and it's so direct composite means IDS.
Okay, thank you. Going to the next.
But I have a question for you. So you didn't.
Yes.
I want to hear you guys. So give me an argument because you are studying that, and I'm not sure if you are using Optibond FL there in Geneva, but give me an argument why you are taught not to use Optibond FL if there is one.
I'm gonna let the students reply. So if anyone wants to reply to Pascal, guys, you can go.
The courageous one.
One of the reasons is that if you're close to the pulp and you're gonna etch all the dentin, including the one close to the pulp, you can cause postoperative sensitivity
with Optibond FL.
Exactly.
So have you had cases where you've etched deep dentin with Optibond FL and you had postoperative sensitivity?
No, not myself, but I don't have that much experience. So what I try to do,
I can tell you, I've bonded hundreds and thousands of teeth in deep dentin with Optibond FL, total etching and sensitivity 0. I had in my own mouth, and so to me that's not an argument that's sufficient because I don't see of any data really proving that point. But I understand it's a common sense. Okay, I don't etch deep dentin. You have to know that some people etch pulp, and they are so they do direct capping with adhesives, and it can work. Why? Because the goal is to prevent bacteria to enter the pulp. That's the goal of direct capping. So I don't think that's enough for me, at least. But I've heard that many times, and I was pretty sure that would be the argument that would come. But I don't see too much substance out of it. Okay, thank you, Marta, for taking courage to answer.
Okay, great. I just have one remark because this is a discussion that we had at university between Optibond FL and other adhesive systems. There is also technique sensitivity that can be, let's say, in favor of other kind of systems, let's say self-etched adhesives. But we know for sure that literature shows us that Optibond FL is the gold standard. So most likely we won't have.
Yeah, and let's talk about these other adhesives like SE bond. How do you deal with different types of dentin when you use SE bond?
I'm sorry.
How do you deal with different types of dentin when you use SE bond, like a sclerotic dentin versus fresh young dentin? How do you make a difference?
In terms of
the way you apply the adhesive.
That's a good question.
That's a problem, right? Yeah. Okay. How do you so with Optibond FL you can etch the dentin selectively based on the type of dentin. When I have sclerotic dentin, I'm etching sometimes these very glassy dentin that you have that's hypermineralized. You etch it longer. Selectively etch that longer because we know it needs a longer etching because it's more mineralized. So you can do that with a total etch. You cannot do that with a self-etch. So self-etch agents don't have this capability. And in our research, the bond stability was not as good as Optibond FL. Now, I want to answer also to Marta by telling you that if you have postoperative sensitivity with a total etch like Optibond FL, that may be also because you didn't manage shrinkage stress correctly. And that's another problem. And I'm extremely careful about that. I am a big fan of the sandwich technique, but not the old-fashioned sandwich technique, what I call the super closed sandwich technique. And if you look up Medline on that, we published a few articles. A super closed sandwich, that means placing the glass ionomer after you do the dentin hybridization. And you use the glass ionomer as a giant non-shrinking filler. And that is releasing the shrinkage stress enormously. That's what Dr. Krejci would call the selective bonding technique.
Okay.
But in my case, I would put the adhesive before putting the GI in the tooth.
I have Nicolas asking what you really think about Scotch bonding universal.
Okay, so it's basically a self-etch. You can use it as a self-etch, but you need to add a hydrophobic layer to it, right? So it needs reinforcement of the hybrid layer because it's a thin adhesive. It's not going to polymerize well in an IDS layer. So you need to cover it with flowable or with hydrophobic resin. It's going to work for sure if you because we don't have numbers of what dentin bonding strength is required, right, for long-term performance. We know that the dentino-enamel junction, very important article by Urabe in 2000, the dentino-enamel junction is about 50 megapascal of microtensile bond strength. So those are the numbers we need at least for an adhesive. So if you have an adhesive that's tested at less than 50, I would not even consider.
Okay.
If I just can comment, one of the reasons also that we use Scotch Bond a little bit more at the university was that one of the argument is that if you do a total etch, like with Optibond, it can cause like collagen fibers to collapse, and it could affect the adhesion. So that was also another argument why we were using Scotch Bond.
What do you mean by collapse?
So that the fact that the acid of the etching would be too strong for the dentin, and it would.
Yes, but Optibond FL has an absolutely unbelievable primer that has the ability to raise the collagen back. And we've done tests of different ways of drying. You could see that. We have one article that was published in the Journal of Aesthetic and Restorative Dentistry. It was about air dry versus suction dry the adhesive and after etching. So when you etch, the way you dry the dentin, right? And we use like super strong air blow or very gentle suction. Actually, you know what? With Optibond FL, when you air dry it stronger, it was working even better than gently suctioning the excess of solvent of water. Same thing with the primer. So actually, we found, according to our research, that it's even less technique sensitive than other adhesives because it's not sensitive to the way you dry the dentin. Because of the primer's ability to re-wet, because the primer in Optibond FL has this amazing cocktail of a solvent, water, alcohol, and all the three different monomers. That there's a monomer that has affinity for collagen, there's a monomer that has affinity for calcium, and there's the hydrophilic monomer, and then water, alcohol. This primer has the ability to recover your hybrid layer and re-wet it.
We have Didier here, and I'm pretty sure he would like to say a few words. He was commenting on what we were talking about. So Didier, if you want to share your thoughts.
Hello, Pascal. How are you?
Didier, congratulations on your talk with Newton. I had to leave to come to this one, but I'm sure it was absolutely amazing as usual.
But it was nice. It was nice talking between friends, and it was really nice to have you with us. I jumped basically just from the Instagram meeting to yours. I've been very silent because I so totally agree with everything which you said. That I didn't feel that my intervention was needed. I might just bring an additional comment, maybe reporting an experience that has not been just like a small number of restorations. I tell you the story about a resin-modified glad ionomer that we found, but through an in vitro research, we were looking for a base material that would allow to absorb polymerization stresses more efficiently than just doing a full composite buildup. That was probably 20 years ago, when the volumetric shrinkage of composites of this period were in the range of 3%. So that was a little bit demanding in terms of handling polymerization stresses. So we tried different base materials, and we found that a resin-modified material that was called diorite was having a very unique property, that the first setting reaction was type sort of acid-base reaction, the typical setting mechanism of glad ionomers, and you would have then a cross-linkage developing through the formation of double bonds, like the composite. The other way around. The first setting mechanism was light curing with double bond formation, but no cross-linkage, and the cross-linkage was an acid-base reaction from the glad ionomers. I'm sorry, because I've been talking a lot, I'm getting a little bit tired. And this material had a very unique property. It was rather elastic at the beginning of the setting process with a very low E modulus, and we were gaining strengths over time, but that was developing over several days, if not weeks. So that was a truly unique material, and the adaptation of restorations on the load was fantastic compared to a normal full composite restoration. So then, of course, with these results in mind, we went on patients, and after a couple of years, we started to observe cracks in a very unusual way. We used that material to build up the pulpy chamber in non-vital teeth. We had teeth cracking, and little by little, we realized that the problem with this material was too much water absorption. So to make a long story short, when we discovered that, the consequences were so severe and so detrimental to the survival of the teeth, which we restored with this technique, we convoked all the patients back. So we had nearly 1,000 restorations placed in the mouth. The cost for the practice has been close to 200,000 euros just to replace all the restorations. We hired a student, because in those days we didn't have everything on the computer, so we hired a student to review every single file in the practice to be able to recall patients and change the restorations. The nice part of the story was that we used Optimum FL. That remind me every time we speak about those MMPs, those enzymes which have potential to degrade the collagen fibers. Of course, if you mess up your adhesion, you might have a lot of nano leakage. But I can tell you that we took away hundreds of restorations, each of the practice members. And when you take out, we started basically 3-4 years after placement. It took up to 10 years until we could remove all the restorations which we placed. It's nearly impossible to feel the difference between the bulk of dentin and the restoration, and the interface is so perfect that was maybe a very difficult way to learn about the incredible performance of that material. But when you gain that kind of trust, first you start to make to give different considerations when we speak about some phenomenon which we observe in the lab, which are maybe not clinically relevant. And I can just agree 300% with what Pascal was saying.
Yeah.
It's not, when you use a self-etch system, since every self-etch system requires etching of enamel, you get in the exact same problem. That might be even worse, because when you don't have a good etchant, you place it on the enamel, it's flowing everywhere. That is a very common finding. And with the self-etch, if you double etch dentin, you mess up the adhesion a lot more.
Absolutely.
Than if you leave etching for a little more on dentin with the Optimum FL, or if you dry a little too much.
Absolutely. And Didier, I would say even that if you are part of the self-etchers clan, you should do immediate dentin sealing even when you do direct restorations, because that's the only way to seal dentin without over-etching dentin. So you do dentin first, then you do your enamel finishing, and you etch the enamel. So IDS is even indicated for self-etchers, right?
And that's exactly, in fact, this technique, the selective bonding concept, which maybe was not selective, but that was the idea of Professor Krecci when he developed that technique, that they will seal dentin with a self that was not the modern self-etching systems, it was with previous generations. But first to seal the dentin so that when you etch enamel, you don't take the risk to contaminate dentin with your etching. Of course, it's a bit complicated, but the concept was already there to avoid etching dentin for self-etch systems.
Totally. And I'm really excited when I hear you talk about those cases that failed, but then you had to replace, and you could witness, you had a direct eyewitness of the optimum performance. And to me, that's it. That's like the story of the talking pig, Alexandre?
No, I don't know. I don't know it.
Oh my gosh, you have to know the story of the talking
but
pig.
I'm all ears.
Okay. So what Didier explained, Didier is not a talking pig, but what he said is similar to the story of the talking pig. Because what is it? Imagine that a scientist come to you and he says, listen, I have a pig. He brings a pig with him. He puts it on the table in front of everybody, and this pig can talk to you, right? You are like, what? Are you crazy or what? What are we talking about? Yeah, he can talk. So the question now is, do you need a meta-analysis study, a 20-year study, meta-analytical analysis of studies to prove that pigs can talk?
Obviously not.
Okay, thank you. Other example, do you need a meta-analytical study to prove that if you have a parachute, in case of an airplane failure, you have more chances of survival? Obviously not. If you want to be in this study, by the way, you're welcome. I mean, give me a break. There are things that are talking pigs. Now, I agree with Didier. We've been all scared by MMP's degradation and that stuff. Yes, but then explain to me what Didier just said in view of MMP degradation and all that stuff. Okay, let's continue, Alexandre.
I get the point.
Thank you so much, Pascal, to make the comments on meta-analysis. It's a beautiful concept, but it doesn't apply to restorative dentistry so well, finally, because when you do meta-analysis, I don't give any name because Pascal might know. I think we spoke about it together. Where you have a meta-analysis, you have like maybe 100 studies, and they run the meta-analysis on 2 or 3 studies. So basically, they throw away 99% of the information. And of course, it's very technically, mathematically, but that's very often poorly relevant to the reality. So we need to be extremely careful with meta-analysis in restorative dentistry. That might apply beautifully to some other medical fields, but that really the number of confounding factors, it's not because the protocol of the study is the same that other confounding factors do not interact with the results. Meta-analysis, I personally don't like at all in restorative dentistry. I think it's a huge conceptual mistake.
And by the way, just to come back to the topic of IDS, Alexandre, because we were still in this topic, right?
Yes, exactly, yes.
IDS is a universal technique.